Hi everyone, good evening. How are you all? Good evening, guys. So it's 7. Let's start. You all here? Great. Amazing. So there are people live on the YouTube as well. Yes, guys, your voice is mute. That's true because there are almost right now 261 fellows in the Zoom meeting. Right now, we have kept everyone on mute, but definitely once the webinar is over, the question answer session, you all will be unmuted. By the time you can type in the chat box, okay? Because sometimes it's a chaos when someone joins in between, someone leaves in between. So because of the mic operations with the people, that's tough to manage. So that's why we kept you all on silent, right? And once we are done with the webinar, once we are done with the session, we will open everyone of you to speak and you can talk to us. And I will request everyone to please switch off your videos as well, please. Okay. Good evening, everyone. Good evening. Good evening. So I will not take much time. I will just start. Okay, guys. Yes, so let me open the top. Tilson Thomas, your video is on. Can you please keep turn off your video? Otherwise, we have to do that. Asma Anjum Saif Ahmed, can you please switch off your videos, guys? Yep, your videos are visible. Okay. Okay. So, guys, again, good evening, and I welcome you all to this wonderful webinar. Wonderful demo class, I'll say. And the demo class is for our upcoming course that is going to start, the next Sunday, I mean, upcoming Sunday. But I thought like before going to the course, we should take one demo class and we should do one open class for everyone. And today's class is not just, half an hour or 45 minutes demo. But today's class will be quite long. I'll take it for 1.5 hours. You have to be there because if you want to learn about a stroke, I will take the entire stroke. I'll not leave in middle, or I'll say like you come and join us for if you want to learn more about a stroke. Okay, stroke will be completed today for sure. Okay, MD Asif and many of you are having your videos on. Can you please put your videos off, guys? Because that causes inconvenience in between, right? That causes inconvenience. So please stop your videos. Otherwise, someone from my team, can you take care of these videos? Can you please off these videos, turn off the videos, please? Yes, please turn off all the videos. Someone from my team, can you turn off all the videos? Guys, videos off, not on. Videos off, everyone. Right? Okay. Anyways, that's okay. That's perfectly fine, not a problem. Now, so today's class, as you know the title of the class also, today's class is going to be on stroke, right? And why this class? So before I go to the class, I will just tell about our course, a little bit about our course. So this is our course. Many of you have registered. We got around 250 registrations already in this course, guys. 250 registrations. Okay, you can see this is our upcoming course. CliMed Edu is coming up with this course. This is 3 month certificate course in neurological and psychiatric disorders. So, and this is one of the module of master certificate course in pharmacotherapy. So master certificate course in pharmacotherapy has 7 modules. Okay, 2 modules are already completed on nephrology, cardiology, and now this is the third module on neurology and psychiatric disorders. Okay, so there are 7 modules total. If you want to get the master's course in pharmacotherapy, then you have to complete all 7 modules, right? But this is not like you cannot get enrolled into one module. You can definitely take another, I mean, you can take one module also, right? So if you are interested in this module, you can take this module and you can get the certificate of this module only. And every module has the 3 month certificate course, right? Every module is 3 month certificate course, right? And this entire master certificate course is around 1.5 year, around 18 months long. Okay. So this module has neurological and psychiatric disorders, and you can definitely join it if you wish to. So the target audience is every pharmacy students, medical students, nursing students, and definitely you will get the certificate at the end of the course. And I mean, every module you will get the certificate, and whoever achieves all 7 modules, whoever completes all 7 modules will get the master certificate at the end. Okay. And definitely we are teaching from the top-notch books like Harrison's, Davidson, and DiPiro. Right, we are not taking any other books. We are teaching you from Harrison, Davidson, and DiPiro's, and the latest clinical guidelines is. Okay. So in this course, in this particular course, 3 months course, we are going to teach you Alzheimer's, multiple sclerosis, epilepsy, and Parkinson's disease, TIA, and stroke, that I'm going to take today as well. And then in psychiatric disorders, eating disorders, depression, anxiety, bipolar, schizophrenia. And if it is written here like one disease, if I'm talking about stroke, then you will be knowing all about stroke. All about stroke means from very basic of clinical characteristics to sign and symptoms, and the risk factors, etiology, and then pathophysiology, and then the management, prevention, treatment, algorithms, new guidelines, everything you are going to learn, as you will see in today's demo class also. Okay. So all disorders, neurological or psychiatric disorders, will be completed, and I will be taking most of the classes. I usually don't take the pharmacotherapy classes in last 2 batches. I didn't take in last 2 courses, but this time I'm going to take most of the classes. Okay, guys. So here, at the end, you have to get the certificate, and the certificate, there are 2 criterias: 70% of live attendance in the classes, live classes, and you have to complete the final quiz and assignments, right? And then you will get the certificate. But uh, classes will be every Wednesday. As this class is there today at 7 p.m. Wednesday, every Wednesday there will be the class at 7 p.m. Okay, Sunday or I mean next Wednesday we will start the course, right? So here you can see the last date to register is today. Okay, last date to register also is today. So if you guys are willing to register, you can register by tonight only. Okay, every one of you guys can register by tonight only. If you wish to register for this course, you have last chance, because we already have 250 students in this course. So I mean, if you are interested after this class, if you feel like you should join this course, you can definitely join this course. Okay, I'll be teaching most of the classes. So with that, I'll just end here and I will start the class. Okay, so let me share my screen, guys. I can see there are almost 50 plus people in YouTube, guys. Hello, thank you very much for joining from YouTube. And so now, guys, please confirm if you can see my screen, and if you can see my laptop screen and full screen. Can you please confirm if it is full screen? Can you please confirm, guys? Thank you. Thank you very much. Thank you very much. No, 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 no. Please don't request for recording. Recordings we are doing. You will get the recordings at the end, and you can check it out in the YouTube also live. Okay. So guys, let's start. Okay. So I'm going to take the stroke today, and yeah. So let's go to that. So there is no disclaimer. I mean, there is no conflict of interest to declare, because this session is completely prepared for the educational purposes, using the information from real-time sources, guidelines, and the books. Okay. So my style I will take here. I'll use my style of teaching here. I will start knowing my audience first. So there are a few questions first to all of you. All of you have to be, very interactive. All of you have to answer these questions, and then only we will learn from these questions. And then there is a full-fledged case, guys. Okay. today's stroke case is going to be a fantastic learning for all of you. I promise that. Okay. And at the end, there'll be one feedback form as well. There'll be one feedback form as well. Just wait for a second, guys. Okay. Just give me a minute. Just give me a second. Then I'll start. Yes, guys. So I'm here. I'm so sorry. So, guys, what you have to do is, for the certificate, there is another criteria for today. You all have to stay till the end with me, and at the end, you have to fill a feedback form, and that will be your attendance form as well. And remember, whoever is staying till end and filling that form will get certificate. Okay. I am not going to listen if you left the meeting 10 minutes before or 5 minutes before. I don't mind if you just learn and go, but if you want the certificate, you have to fill that form at the end of this class. Okay, at the end of this class. And please don't ask me in between. If I'm teaching, don't ask me when will the class end, because this class will go for at least 70 to 80 minutes. Okay, so up to 8:20, 8:30, this class will go. Okay. So let's start, guys. Let's start with the first question. Let's not waste the let's not waste much time. Okay, it's already 7:13. Yeah, so first question to all of you is here. Yes, guys. First question to all of you is, you don't have to write your names, guys. I have all your informations when you registered. Okay, I'll get all the informations. No, no, there is no need to turn off because I want the answers. Yes. What is the answer, guys? What is the most common cause of an ischemic stroke? Ischemic stroke. Yes. Many people are writing B, many people are writing C. Okay. 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 Perfect. Perfect. Fantastic. Like this, I want answers. So let's understand the things first. Let's understand the things first. My question here is, what is the most common cause of ischemic stroke? Okay. Now, many of you are joining for the first time. There are first year, second year, and third year of PharmD and even MBBS first year, second year students I saw. What is exactly the stroke is, right? What exactly the stroke is, right? So, stroke is a problem when we don't get the sufficient oxygen supply to our brain. Okay, and that happens in multiple situations, and one of the situation is stroke, right? And stroke means either there is a clot, formed in the arteries which are going to the brain, which are supplying the blood to the brain. Okay, either the clot is there or the arteries are busted. Okay, and because of that, the oxygen supply is restricted and it is not going to the entire brain. It is not going to the entire brain, right? So that is causing the less supply or no supply to the brain tissues, no supply of oxygen to the brain tissues. And because of that, there are the symptoms and a lot of other things, lot of sign and symptoms occurs like paralysis and blurred vision, slurred speech, that I'll come to that. Okay, but there are, first let's understand what exactly the stroke is and how, if I'm talking about ischemic stroke, then what are the other types of stroke? What are the Okay, so if I'm talking about ischemic stroke, then what are the types of stroke here, right? So let me tell you guys, there are three types of stroke. Okay, there are three types of stroke. Let me go to the next slide, then I'll come to that. So the correct answer here is atherosclerosis. I'll come back to this and I'll answer. I mean, I'll discuss all the options here. I'll discuss all the options here. So before that, let's understand what exactly are the, I mean, how many types of stroke are there, right? So there are three types of stroke. First, if I talk about is first is ischemic stroke. Okay, ischemic stroke, that is like because of the clot, because of the obstruction, and obstruction can happen because of the clot formation, or maybe the emboli which is traveling, or thrombus which is emboli which is traveling from some other vessel, like sometimes people get the atherosclerosis in cardiac vessels, like in the vessel of heart, and from there some clot or some emboli has traveled to our arteries which are going to brain. Okay, so that obstruct the blood supply, to the brain, and that causes the ischemia also there, that causes the injury also in that vessel there, right? Because of that, the blood supply is not proper there, and because of that, oxygen supply is also not there, right? When blood supply is not there, oxygen supply will not be there, right? So this type of uh, stroke is called as ischemic stroke, because that is happening because of the clot formation, that is happening because of the emboli which has traveled from any other place, and that any other place could be your heart, that other place could be your deep veins, like sometimes in the deep vein thrombosis also, there is the thrombosis, and that thrombosis in form of emboli travels to your brain cell, I mean the brain vessels, right? The vessels which are going to brain, as you can see here, these are the usually, this is the carotid artery, we call it carotid artery. Okay, we call it carotid, carotid artery. Okay, carotid artery, which goes to the carotid artery, and there are three carotid arteries, major, I mean three branches of carotid arteries. One is central carotid artery or middle carotid artery. Okay, middle carotid artery, and other are left side branch, or right side branch of carotid artery, which supplies the blood to the different zones of the brain, right? So this emboli can go anywhere and can stuck anywhere in the vessel, and can obstruct the blood supply or the oxygen supply to the brain tissues, and that causes the symptoms, that causes the problem, right? So this is called as ischemic stroke, right? And the second type of stroke is, if I say this is a part of, or this is the initial sign of trans ischemic stroke. Okay, this is the initial sign, I mean this trans ischemic stroke is the initial sign of major ischemic stroke. One second, why am I? Oh, my pen is not working, but are you guys, so sorry, my pen was not working. Okay, no problem. I'll just, yeah. So this trans ischemic stroke, if you check out, this second type is, it is the initial, kind of initial stage, or this stroke is also known as mini stroke. Okay, this stroke is also known as mini stroke. Why we are calling it mini stroke? Why we are calling it mini stroke, not the full ischemic stroke? Because in this there is no artery blockage, in this there is no obstruction. Okay, this is just a this is not a permanent thing. Ischemic stroke could be a permanent thing, but this trans ischemic attack, what we call it trans ischemic attack, is just the attack, and it is a temporary clot. Okay, it is a temporary clot. Majorly the things which come from the another vessels, like the, and those clots are not that big that they can stuck in the vessel, or they can completely stop or injure the vessel, or they can completely stop the blood supply to the brain tissues, right? But what is this is, this is in this transischemic stroke, there is a little emboli, which is traveling through the vessels, and it can stuck somewhere, but it doesn't stop all the 100% blood flow. Okay, so because of that, because of this, there are the symptoms occurrence similar to ischemic stroke. But why we call it a mini stroke? Because it goes It just goes in 24 hours. Okay, the symptoms and signs of the stroke goes in 24 hours. Okay, it goes in 24 hours, right? And guys, very interesting fact I'm going to tell you here. Very interesting fact I'm going to tell you here. All the stroke, if I tell the magnitude of the stroke, right? If I tell the magnitude of the stroke, magnitude means what is the percentage or epidemiology of the stroke, right? So ischemic stroke, this ischemic stroke is almost 75% of all type of strokes. 75% of all type of stroke is ischemic stroke. Okay, and then rest 13% is hemorrhagic stroke. Rest 13% is hemorrhagic stroke. So you will tell what is what is transient ischemic stroke, right? The question is, if this makes 100%, then what is transient ischemic stroke? Transient ischemic attack is a preliminary sign or a temporary stroke, which, in which within 30 days, fact here, within 30 days, 15% of the transient ischemic attack turns into the ischemic attack, the permanent severe ischemic attack that can lead to death also, right? So that's why the transient ischemic attack is called as mini stroke, or the sign of upcoming danger, right? The sign of upcoming danger, which could be ischemic stroke. So majorly, now if you understand, majorly there are two types of stroke. One is ischemic, one is hemorrhagic. But there is another thing which is a similar sign and symptoms of similar sign and symptoms to ischemic stroke and similar pathophysiology to ischemic stroke, but that resolves within 24 hours, and it is a sign to take care of all the risk factors. It is a sign to take care of all the problems. It is a sign to take care of all the social habits and all that I'm going to talk in the next slides, right? So this is a sign, transient ischemic attack is a sign for the ischemic attack, the severe ischemic attack. So you can understand how it turns into the severe ischemic attack. The 15% of mini stroke turns into the severe ischemic attack. Okay, so I hope you understand. So here, look at this. Now I'll come back to the question. So what is the most common cause of ischemic stroke? See, intracranial hemorrhage is hemorrhagic stroke, right? In this, so what is the major difference here? What is the major difference here, right? What is the major difference here? Intracranial hemorrhage means when this blood vessel, which is actually, in ischemic attack, which gets clot or emboli, but here the blood vessel burst out. Okay, here the blood vessel burst out in the tissues, in the brain tissues, and because of the burst out of the brain tissue, because of the the brain, I mean, because of the burst out of the brain, I mean, these carotid vessels or the vessels which are carrying blood to the brain, and then those burst out into the brain tissues, and that causes the problem. That causes the different type of sign and symptoms, and that causes the different type of neurological problems. That causes the different type of neurological problems, right? That causes the different type of problems in that, right? So intracranial hemorrhage or hemorrhagic stroke is different type. The management is again different. See, you have to understand here, there are two major types, as I told you, ischemic stroke and hemorrhagic stroke, right? So hemorrhagic stroke has different type of management, different sign and symptoms, and all different pathophysiology, because here there is no clot. Here complete, the part of the vessel or the entire vessel is burst out, and there is a bleeding. There is a bleeding into the brain tissues, and that is damaged. Okay, so that part is damaged, and that needs usually the surgeries, and binding, I'll come to that part later. Okay, and atherosclerosis is the main reason for ischemic stroke. Atherosclerosis means the clot formation, right? Atherosclerosis means the clot formation. Either that is a full-fledged clot or that is emboli. Emboli means the small part of the clot which can travel through the vessels to any other places, right? So it is traveled, this emboli has traveled usually in case of trans-ischemic attack, or maybe sometimes in case of ischemic attack, it travels from the cardiac, cardiac vessels or deep veins, okay, in the deep vein thrombosis, right? So this is the major cause, and hypertension and atrial fibrillations are not the cause, are risk factors. Okay, are the risk factors for ischemic stroke. These are the risk factors for ischemic stroke. Understand? Okay, cool. Okay, now I'll go to the next question. Okay, I'll go to the next question. So this question is over. Now, next question for all of you is, which of the following is the key differentiating factor between a transient ischemic attack and the ischemic stroke? Yes, guys. Yes, hypertension also causes the stroke. That's why I'm telling this is the risk factor. This is the risk factor. Okay, hypertension, smoking, and all other risk factors. I'm going to talk about those. Yes. A, B, C, I'm getting completely disoriented answers for me because all the answers I'm getting from you guys. See, okay, let me describe. Let me describe. See, first is location of the blockage. In both the trans-ischemic and ischemic stroke, it will be carotid artery. Okay, carotid artery or branches of carotid artery, right? Branches of carotid artery. Okay, carotid artery, branches of carotid artery. So location is similar. Location is not different. Now, severity of the symptoms is also not a different thing because the onset of symptom is almost severe in trans-ischemic attack also. Okay, severity of symptom is not that different. Severity of symptoms is not different because of the less pathophysiological effect or changes in the vessels. It disappears within 24 hours usually. So that's why it can call as mini stroke or the sign of ischemic stroke, the severe ischemic stroke, upcoming severe ischemic stroke. The severity here is not different. Okay, remember, severity here is not a different thing. Presence of risk factor is same for everyone, same for everything. Even for the hemorrhagic stroke, even for the ischemic stroke, even for the TIA, the risk factors are same. The only thing which differentiate TIA and ischemic stroke is duration of the symptoms. Okay, the only thing which differentiate between TIA and ischemic stroke is only duration of the symptoms. Okay, duration of the symptoms, because ischemic stroke is a permanent thing and TIA is a temporary thing. TIA is a temporary thing. Understand? So the answer here is nothing but duration of the symptoms, right? Answer here is the duration of the symptoms. Next question to all of you. Which artery is most commonly affected in ischemic stroke, guys? Yes. Which artery is most commonly affected in ischemic stroke? Fast. MCA, AC. Basilar artery. Are you guys sure? Who is written C? What is basilar artery? And tell me the answer of basilar artery, guys. Yes. Yes. Who is writing basilar artery? See, basilar artery, I'll tell you. I'll tell you. Okay. I'll tell you here. See, look at this. Look at the question first and let's understand. Okay. See, in the last slide, we have seen, see, there usually, this is the neck. This is the neck of the, like a human, right? And this is the head. Suppose this is the head, this is the back of the head and hypothalamus and all. And see, these are the two major vessels. These are the two major vessels. Let me change the color so you can understand it easily. You can understand it easily. So here there are two major vessels. Okay, one is vein, one is artery. Red color is artery and the blue color is vein. So we don't have to take anything with the vein here. So this artery is called as carotid artery. Okay, carotid artery, right? Carotid artery. So here there are three parts. There are three branches. There are actually three branches after this. When it enters to the hypothalamus, there are three branches. Okay, and the one is going to the anterior side, frontal lobe of the head. Okay, one is going to the back, our hypothalamus and other things. One is covering the entire brain and the mid region of the brain, that is called as MCA, mid carotid artery. One is anterior carotid artery, one is posterior carotid artery. Posterior carotid artery is going to the back side of the brain, and the anterior artery is going to the frontal lobe of the brain, right? And these are supplying the blood to the entire brain, right? But now what happens is, what affects majorly here, if you look at the MCA, middle carotid artery, if the clot happens in the middle carotid artery, that is also known as central carotid artery, that affects the major area of the brain. Okay, that affects the major area of the brain, and that causes the severe stroke. That causes the severe stroke, and majority of the ischemic stroke happens, the severe ischemic stroke happens from the MCA. And if there are, usually trans ischemic attacks are also happening in the MCA, but in that the majority is not exactly MCA. There are, anterior and posterior arteries also. So that is the sign of, the mini strokes, right? Or the trans ischemic strokes. There are the clots going to the posterior anterior artery also. But in the ischemic stroke, the major ischemia or injury happens in MCA. MCA is middle carotid artery. Unable to hear, ma'am? Ma'am, can you hear me? Yeah, my voice, is it reaching you? Someone is writing, ma'am is writing, I'm not able to hear. Ma'am, is it okay? Okay, great. Thank you. Thank you very much. Thank you. Okay, so this is like the answer here for ischemic stroke is middle cerebral artery, okay, or carotid artery, middle cerebral artery, okay. MCA is middle cerebral artery, okay. So that is the answer here, right? That is the answer here. Now, the next question to all of you is, yes, which of the following is a typical symptom of hemorrhagic stroke? Yes, guys. Yes, please. Everyone. A, B, A, B, A, B. Sudden loss of vision, gradual onset of weakness, chest pain, severe headache. A, B, A, B, A, B, C, A, B, C. Okay. Again, like bifurcated answers. Okay. So guys, look at this. Understand. Let's understand one by one. Let's understand one by one. See, sudden loss of vision. Sudden loss of vision is not a common symptom of stroke. Okay. That is one of the symptom of stroke, but not common. It happens only in 5 to 15% of the patients, sudden loss of vision. Remember that what I'm saying. Try to understand that every aspect of answers here. So the sudden loss of vision happens only when the your retinal arteries are affected. Okay, when the arteries, retinal arteries means the frontal lobe, the anterior artery, anterior cerebral artery is affected. From that, there are retinal arteries going to the eyes, right? So if the clot is there and that area is affected, or that arteries, or those arteries are affected, small arteries, definitely capillaries we say, which are going to the eye or the retinal areas. If the retinal capillaries are affected, in that case only sudden loss of vision happens. Okay, but in case of usually the severe ischemic stroke and sometimes hemorrhagic stroke also, that is not frontal lobe. Okay, that is the middle cerebral area. Okay, in that the symptoms occur, right? So sudden loss of vision is not a common symptom of hemorrhagic stroke. Okay, and then gradual onset of weakness is also, it is not, it is a common symptom. It is a common symptom, but usually it happens in ischemic stroke. Okay, and chest pain is not a symptom of stroke actually. Okay, that is the symptom of cardiac arrest. That is a symptom of myocardial infarction called heart attack. That is the symptom of mitral regurgitation. That is a symptom of other cardiac problems. Okay, but usually not for the hemorrhagic stroke. So what is the major symptom of hemorrhagic stroke is severe headache. And why severe headache? See, there is a reason. I'm explaining each and every each and every aspect, each and every answer to you. So why severe headache? Because hemorrhagic stroke, there is a simple pathophysiology. The cerebral arteries are busted out inside the brain areas, okay, inside the brain tissues. And it's not inside means the inside the brain cells or brain tissues. These veins or these capillaries are busted out, and because of that there is the blood accumulation. Okay, there is a blood accumulation, right? And because of that, sudden headache appears and the severe headache appears. Okay, and this headache in hemorrhagic stroke, guys, there is, listen to me very carefully, this headache in the hemorrhagic stroke, this headache in the hemorrhagic stroke is also known as, this headache is also known as worst headache of my life. Okay, worst headache of my life. This is also known as worst headache of my life. Hemorrhagic stroke headache is severe, and this is at the peak severity because of the blood accumulation or continuous blood loss from the artery there in the cerebral area. Okay, and that is also known as worst headache of the life, right? Worst headache of my life, it is called as worst headache of my life, right? So if you get sudden severe headache, you must go and check out for that. I mean, usually that is the major sign of the hemorrhagic stroke. That is the major sign of hemorrhagic stroke. Okay, not totally busted, I mean the part of it is busted and there is a blood loss and there is a blood accumulation inside the cerebral area or the brain tissues. Okay, so the answer here is severe headache. And next question for all of you is here: what is the primary imaging modality used in the acute diagnosis of stroke, guys? Yes, people. Yes, people here. MRI, 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 MRI. Okay, MRI. Mm-hmm. Okay, MRI. Okay, guys, listen to me carefully now. Let's discuss one by one. See, the MRI. If I talk about MRI, okay, if I talk about MRI, MRI is superior to diagnose the ischemic stroke. Okay, ischemic stroke, because it gives 3 slices, 2 slices, and ischemic strokes, it helps us diagnosis or detecting the ischemic strokes, where we have to find out the length, the strength, the calcification of clot or emboli, whatever is that. Now it is clot. In the ischemic strokes, that is clot, right? So we have to find out the length and the area and the size of the clot. So MRI helps us in finding the size and of that stroke, and that is most appropriate diagnostic tool for ischemic stroke. Okay, ischemic stroke. Okay, and then CT scan. CT scan is the detection tool rapid detection tool. Okay, rapid detection tool is CT scan, which talks about all type of strokes. Okay, majorly it is the tool for hemorrhagic stroke. CT scan is for the hemorrhagic stroke. And when I'm writing acute diagnosis, that means usually we are talking about hemorrhagic stroke, because ischemic strokes are not that acute. I mean, in comparison to hemorrhagic stroke, ischemic strokes are not that acute. It takes time. Okay, I mean, definitely we have to control within 2 hours and 4.5 hours. I mean, there are the protocols that I'll tell you, but usually when I'm talking about the acute diagnosis, we are talking about hemorrhagic stroke. And if it is acute ischemic stroke also, CT scan is most appropriate tool for the rapid detection. Okay, CT scan is the tool for the rapid detection. And ultrasound usually is not a tool for the acute diagnosis. Ultrasound we use only when there is a central carotid artery blocked. when there is central carotid artery blocked. Okay, X-ray doesn't help here much. X-ray doesn't help here much, right? X-ray doesn't help here much. X-ray helps only in the hemorrhagic strokes, but usually in ischemic strokes, it doesn't help. Okay. So the answer is CT scan here, because that helps in both the types of stroke acute diagnosis. That helps us in the both the type of strokes, ischemic, either ischemic, that is, or hemorrhagic. Okay. Now, okay, so where is my, yeah. Yeah, so this is the next question. The recommended time window for administering tissue plasminogen activator in ischemic stroke. Yes, guys. Yes, what is that? Answer, guys. Recommended time window for administrating tissue plasminogen actor in, activator in ischemic stroke. Yeah, guys, fast. Can I get the answers from you? A, A, B, A, B, A, B, A, B, C, A, B, C. Okay. By 3 hours. Okay. B, 3 hours. B, 3 hours. C, D, A. Okay, let it be. Let it be. It's okay. You don't know the right answer. Many of you don't know the right answer. So right answer is 4.5 hour. Okay. Right answer according to the guidelines. Why the guidelines have decided 4.5 hour? Because they did multiple clinical trials. They did multiple observational studies on the stroke patient, like up to when tissue plasminogen activators are most affected in stroke. Okay, they did multiple clinical trials, multiple observational studies to find out like what is the actual time window, and up to when the TPAs are TPAs can be given in a stroke patient, in a ischemic stroke patient. So the answer here is 4.5 hour. Okay, answer here is 4.5 hour, right? So this is because of the scientific reasons. This is because of the scientific studies, or the observational, or interventional, not interventional, observational or clinical trials. That is 4.5 hours. Okay. Now my question to all of you is, what is FDA approved TPA for stroke? FDA approved TPA for stroke, guys. Yes. FDA approved TPA for stroke. Yes. Yes, please answer that. Yes. Altiplase, absolutely. Altiplase is the FDA approved tissue plasminogen activator for for stroke. Altiplase. Okay. Altiplase is the FDA approved. Right. Okay. So I'll go to the next question and then we'll come to the case. I think that's the last question or something. Yeah. So TIA increases the risk of subsequent stroke approximately by what? 15%, that I already told you. Okay. That I already told you. So TIA increases the risk of a subsequent stroke by approximately what percentage within 90 days? Actually, this is 1 month. Okay. But that is 15%. Okay. Answer is 15%. Right. So I think this is the last question then. Yeah. Which of the following medication is commonly prescribed? Yes, guys, this is the question where we have to discuss a lot, and I want your answer also. Okay. I want your answers also, guys, here. Which of the following medication is commonly prescribed to prevent ischemic strokes in patient with atrial fibrillation? Yes, guys. Yes. Yes, people. Fast, fast. Answers. I need the answers. Guys, if you are not able to catch up in Zoom, I can see there is a 500 all full. Please go and join the YouTube channel. That's okay. That's completely fine. You can join the YouTube channel. ABC, ABC. What is the answer, guys? Read the question first. And if you know, please answer. Which of the following medication is commonly prescribed to prevent ischemic strokes in patients with atrial fibrillation? Yes, people. Warfarin, warfarin, aspirin, warfarin. Okay, wait, wait. Full stop now. Okay. So listen to me carefully. Listen to me carefully. First, I'm not just asking the ischemic stroke. I'm not just asking for the ischemic stroke. I'm asking for the patients with atrial fibrillation and then there is ischemic stroke, right? Then there is ischemic stroke, right? So first listen, first try to understand what is the problem. The problem here is blood stasis in the atria. Okay, blood stasis in the atria. And blood stasis in the atria is something which leads to the clot formation. Clot formation. And why it happens, why blood stasis happens, blood stasis happens in atria, that happens because of AF, because of atrial fibrillation. Okay, this happens because of the atrial fibrillation. And now once the blood, because of blood stasis, clot formation happens, that is called as emboli. Okay, that is called as emboli, and that travel to the cerebral artery and block the cerebral artery. Okay, that emboli blocks the cerebral artery. So where it happens actually, because of AF in cardiac arteries. In cardiac arteries, it happens. Okay. In myocardium, sorry, not myocardium. In the cardiac arteries. Okay. In cardiac arteries, it happens. The blood stasis and blood, because of blood stasis in cardiac arteries, the clot formation happens. And because of because of AF, that is not only happens in cardiac arteries, it happens in atrium also. Okay, it happens in atriums, right atrium and left atrium. Okay, usually in the right atrium it happens. Blood stasis usually is the the major location, main location for blood stasis is right atrium. Okay, major location, as I told you, blood stasis in atria, it is right atria. Okay, right atrium, right? So when the blood stasis happens, because of that, there are the clot formations, and those clots travel through the carotid arteries to the from the cardiac arteries to the carotid artery, and that goes to cerebral arteries, and that makes a clot there and causes the ischemic stroke. That causes the ischemic stroke. So in that case, what you would like to use? What you would like to use? See, in this case, guys, you have to understand a simple thing. Okay, in this case, you have to understand a simple thing. Aspirin and clopidogrel. Aspirin and clopidogrel are not helping. That these two things cannot help in what? These two things cannot help in prevention of thromboembolic events. Thrombosis, right? Or thromboembolic events, we call them thrombosis. Aspirin and clopidogrels are antiplatelets, You understand? Aspirin and clopidogrels are antiplatelets. That's why aspirin and clopidogrels cannot help in prevention of thromboembolic events. Understand? Aspirin and clopidogrel are useless here right now. I mean, in this scenario, in case of atrial fibrillation stroke, aspirin and clopidogrel are not at all useful. Understand? So what will be useful here? There are two things, two other options. If you look at, one is warfarin, one is heparin. There are two things which are, useful here. One is clopidogrel and one is, one is warfarin, one is heparin. So why why we don't give the heparin? Why we don't give the heparin? Because see, when I'm talking about ischemic stroke, we need long-term therapy. You understand that? We need long-term therapy, and heparin cannot be given for long-term because this comes in injectable forms. Simple. Heparin comes in injectable forms, and we cannot give heparin for the longer term. So in that case, we go for warfarin, because warfarin also can be given in oral format, right? It can be given in the form of oral tablets. And that's why warfarin is the choice for prevention of ischemic stroke in patients with atrial fibrillation. because heparin is one of the choice, but heparin cannot be given for the long term. That's why warfarin is chosen over heparin here. And aspirin, clopidogrel are already out because those are antiplatelet drugs and those cannot help in thromboembolic events prevention. Understood, guys? Okay, you understand this? Yes. So answer here is warfarin. Answer here is warfarin. Okay. I hope you understood here. I hope you understood. Answer is warfarin, not the aspirin, clopidogrel or heparin. Okay, not the aspirin, clopidogrel, heparin. Now let's jump to a case. Let's jump to a case and let's understand the case in next 20-30 minutes. So you will understand the entire scenario here. You will understand the entire scenario here, right? So let me come to the case here. So guys, focus now. Now I want your attention completely here. As you were answering in the question session, here also I want your complete attention, right? So look at this. A 65-year-old male presents to emergency department with a sudden onset of right-sided weakness and difficulty speaking for past 2 hours, right? A 65-year-old male presents to emergency department with a sudden onset of right side weakness and difficulty speaking for past 2 hours. His family reports no history of trauma and he has no experienced similar symptoms in the past. So this is happening for the first time. There is no history as well, right? There is no history as well. This is happening for the first time. This is happening for the first time, and the symptoms are sudden onset of right side weakness and difficulty speaking for past 2 hours. So before we go to that, let's understand the risk factors. Okay, let's understand the risk factors. You understood the first presentation of the case? You understood the first presentation of the case? Now let's understand the risk factors, modifiable, non-modifiable. So here, first thing is hypertension. High blood pressure is the risk factor for stroke. Then obesity, definitely. Lack of exercise, sedentary lifestyle is always the risk factor for cardiovascular events, for stroke, for diabetes, for hypertension, right? Sedentary lifestyle, lack of exercise. Then sleep apnea is one of the major reason, again, because sleep apnea leads to multiple lung related problems and cardiac problems. Okay, then heavy alcohol use, smoking or drug use, and cardiovascular disease, high cholesterol, hypercholesteremia is one of the reason, and then diabetes. Okay, major reasons. But in girls, guys, listen to me carefully. My female participants here, female students here, listen to me carefully. The contraceptive pills, contraceptive pills. The recent study says, you go and check out, contraceptive pills are the major reason in young female strokes. Okay, the strokes in young females, contraceptive pills are the major reason. I mean, is one of the major reason. Recent study says contraceptive pills are one of the major reason in the young females for the stroke, for the ischemic stroke and hemorrhagic stroke, both, usually hemorrhagic stroke. Because of the estrogen, high level of estrogens in the body, the peripheral resistance increases. Okay, peripheral resistance increases. Because of that, the blood pressure increases in the smaller arteries, capillaries. Okay, in the end stage arteries or the capillaries, the blood pressure raises, and because of that, you get the stroke. Understand? So these are the major risk factors for stroke. Major risk factors for stroke. What are the risk factors in present case? Let's understand. So this guy, our 65-year-old male, is hypertensive, which is poorly controlled. Last recorded BP was 160 by 100. High diabetes, HbA1c is 7.8 in this case. Dyslipidemia, LDL is 160 mg per dl. Smoking also, he is drinking for past 30 years, 1 pack per day, almost 15 to 20 cigarettes per day. And he is working in MNC. He is living the complete sedentary lifestyle. Complete sedentary lifestyle. Understand? So this is about the case. So what are the major risk factors here? Hypertension, diabetes, dyslipidemia, smoking, sedentary lifestyle. All the risk factors are there in this patient. Almost all the risk factors are there. Right now, for these risk factors, he's already on medicines. For diabetes, he's on metformin 500 mg twice a day. For hypertension, amlodipine 10 mg daily. For dyslipidemia, atorvastatin 20 mg per day. Right now, he's on metformin 500 BD, amlodipine 10 mg per day. So amlodipine is CCB calcium channel blocker for the newcomers, guys who don't know. This is antihypertensive medication, amlodipine, CCBs, and metformin is bigonide, which is one of the first and major choice for diabetes in the recent onset or the early diagnosis of diabetes. We usually treat with metformin, and atorvastatin is again the statin for dyslipidemia, for hyperlipidemia. It helps us reducing the lipids in the body. Okay, lipids in the body, right? Lipids in the body. Okay, so this is about the present case risk factors. Now major thing is how to catch the stroke, how to, if someone comes with such things, if someone comes to you, how you will diagnose or how you will find out that the person or the case which has come to you is stroke. How will you find out? How will you find out? So you have to remember this: be fast. Okay, be fast. This is the formula to catch the stroke. This is the formula to understand the stroke, to diagnose the stroke. Okay, so what is be fast? There is like B for balance. The patient will be having some kind of lose of balance or headache or dizziness or swaying, right? Swaying, imbalance, right? So patient will show any kind of symptoms like loss of balance, headache or dizziness or swaying, right? E for eye, check for eye, there will be the blurred vision. There will be the blurred vision, right? Blurred vision. Then F, look at the face. Face will be drooping. One side of the face will be drooping, as our patient was having the left side weakness. So in that, the face will be drooping. Okay, and arms or leg weakness will be there, one side or both the side or the entire body. Usually, it happens if it is like anterior, based on anterior and posterior, the symptom appears in the left or right side. Okay, so if your one side of arm and legs are going to going weak, that could be one of the symptom of stroke also. Then slurred speech difficulty. Okay, as for speech difficulty or slurred speech is one of the symptom of stroke. Then time to call for ambulance immediately. If you find any of these symptoms, be fast, then call for the ambulance T, right? So how to catch the stroke? Be fast. How to tackle the stroke? How to prevent the stroke? How to prevent the mortality or morbidity in the stroke? Be fast. That is the formula. That is the formula. Be fast. So first, when the patient comes to you, check the balance, check the eyes, check the face, check the arms, legs, or okay, these all are related to stroke. Yes. And then slurred speech. And then immediately call the help, ambulance. Okay. Or let the patient go to hospital. Understand, guys? Okay. Now, sir, this type of stroke occurs in sleep possible? Someone is asking from YouTube. Usually, yes. In the evening times, stroke happens in the evening time and cardiac arrest happens in the usually morning time, 4 o'clock, 5 o'clock. Okay, so there are the pathophysiological changes which happens at the most of the time at that time frames that I'll not go into right now. And but yes, this is possible. Not usually in the, usually it very minor cases, very less cases in the sleep, very less cases in the sleep. In sleep, usually cardiac arrest happens, not the stroke. Okay, usually cardiac arrest happens in the sleep, during the sleep, but not these things, not the stroke. Stroke happens when you are awake, running, sitting or talking or watching TV or simply awake. Okay, usually stroke happens that. But yes, there is always very minor cases, very less cases of stroke happens in the sleep also. But usually when the person is asleep and he is getting such conditions, he is getting some conditions, that usually happens the cardiac arrest. Okay. So sign and symptoms here: face droop on one side, not able to lift the arms, slurred speech, paralysis, blurred vision, dizziness, confusion, difficulty in understanding. Neurological symptoms, all are neurological symptoms. And then problem in balance or coordination, difficulty swallowing, dysphagia, that is one of the sign also. Severe headache for hemorrhagic stroke, loss of consciousness. Loss of consciousness means when there is very severe hemorrhagic stroke or ischemic stroke, anything. Usually, loss of consciousness happens in hemorrhagic stroke, but yes, that can happen in ischemic stroke also, right? So these are the signs and symptoms: face droop, not able to lift the arms or legs, slurred speech, paralysis, blurred vision, dizziness, confusion, difficulty in understanding, problem in balance and coordination, difficulty swallowing, dysphagia we call it, severe headache, loss of consciousness. And these pictures have taken from Lal Path's lab. Okay, credit goes to Lal Path's lab for these pictures. So, and then now clinical sign and symptoms in this patient, in the present case, what was that? Weakness in the right upper and lower limbs, in the right arm and right leg. Okay, in the right arm and right leg. Then positive Babinski sign on right. Positive Babinski sign on right. So guys, can anyone tell me what is Babinski sign? Without looking into the Google, can someone tell me what is Babinski sign? Yes, people. I want to ask you this. What is Babinski sign? Can anyone tell me? And did you ever notice Babinski sign, or anyone have studies or learnt about Babinski sign? Yes, people. Stimulation of nerves. Okay. Where? How? Procedure of Babinski sign. Yes, people. Tell me the Babinski sign. Yes, guys. Lift. Lift foot. Finger, nose, finger test. Okay. Yes. Observed in leg stimulation in the nerves in the leg. Okay, foot reflex. Okay, I'll tell you what is Babinski sign. First, let's understand. See, Babinski sign is actually, it indicates the potential dysfunction in the corticospinal nerves or corticospinal tract. Corticospinal tract is a pyramidal tract in your foot. Okay, in your foot, usually in both the foot. So what the doctors do, someone's video is on. Bipin video was on. Okay, no worries. So what they do is they check, they usually pinch or they usually scratch on the foot. They lift the foot, scratch on the foot, or pinch at the pinch, on the middle of the foot and scratch it up to, upwards towards the toe. Okay, and then they look at the reflexes. They usually use the blunt surface or the blunt pinpoint type of things like pen, right? Like the pen in my hand. They will, like, this is, suppose this is the foot, they will take in between and they will scratch it like this to the toe side, and then they will look at the reflexes. Then they check the reflexes. Usually the neurologist, they do check, they look at the sign of Babinski sign. They look for the Babinski sign. Okay, so that kind of, evaluation is being done. So here in our case, I'll not go into the details of this, but see, in our case, there was the weakness in right upper and lower limbs and positive Babinski sign. Okay, and then slurred speech, but able to follow the simple commands. But the patient was able to follow the simple commands. Okay, and then there was NIH stroke scale 12. There was NIH stroke scale 12. What is NIH stroke 12, guys? Can someone tell me what is NIH stroke? Can someone tell me what is NIH stroke? Yes, guys. Can someone tell me what is NIH stroke? Yes, people. NIH stroke scale. It's a scale. That's fantastic answer. It's a scale. Okay. National Institute of Health stroke scale. Okay. I'm not asking for the full form, guys. See, okay, I'll tell you. There are 11 questions or categories of the questions what are asked or what are assessed in the patient. What are assessed in the patient, and each category has different scorings from 0 to 3, 0 to 2, 0 to 4. Like they check for level of consciousness in 0 to 3, they check for best gaze in 0 to 2, gaze of eyes, they check for the visual fields 0 to 3, they check for facial palsy 0 to 3, they check for motor arms and legs 0 to 4. So they give the scores, and at the end, if the scores are coming into these categories, there are five categories. If there is 0, then there is no stroke. Okay, if there is 0, then there is no stroke, and if this is that goes from 1 to 4, that is minor stroke. That is minor stroke. If NIH stroke scale goes from 1 to 4, that is minor stroke, and if it goes from 5 to 15, that is moderate stroke, and if it goes from 16 to 20, that is severe, I mean moderate to severe stroke, and if it goes from 21 to 42, that is severe stroke. Okay, based on these 10, I will tell you to read it later. You go and check out NIH stroke scale. Okay, so there are the things. So our patient has the stroke scale of 12, and that comes under the moderate score. Okay, moderate stroke. Okay, and there was also the irregular pulse suggestive of atrial fibrillation. So did the ECG, and ECG showed atrial fibrillation in this patient. Okay, that's why I asked the question, which drug is being given for the acute phase of or the prevention of ischemic stroke and atrial fibrillation. Blood pressure right now for the patient is 180 by 10. 180 by 10. 180 by 10. Okay, so these are the symptoms and clinical presentation of the patient right now, right? Okay, next, there are some more things like I forgot. There is right side hemiparesis. There is also dysarthria, that is slurred speech. There is also mild facial droop on the right side. So this patient got the right side ischemic stroke. Right side ischemic stroke. Okay. So now I'll come to the diagnosis of the stroke. So first of all, the blood test. Blood test. What are the blood tests usually suggested for, guys? What are the blood tests usually suggested for stroke? In stroke, what type of blood tests you want to go for? Yes, people. Which blood tests you want to go for? APTT. Okay, full form of APTT. Full form of APTT. Lipid profile. Okay, perfect. Lipid profile. Electrolytes. Why electrolytes? Just question. Troponin levels, okay, considerable, because it could be because of myocardial infarction. Yes, troponin levels are considerable. PTINR. PTINR is very important because PTINR talks about hemorrhagic stroke, and PTINR also talks about the therapeutic, what we say, the therapeutic approaches, to decide the therapeutic approach for treatment of stroke. And PTINR is nothing but your prothrombin time and international normalized ratio for thrombosis, I mean this the thrombin time. Okay, prothrombin time is the time for clotting. Okay, is the time for clotting. Usually we check that, and definitely GlyHB and random blood sugar, and for the hypertension, blood pressure, and electrolytes also we can check definitely. And then lipid profiles, we check for risk factors. And coagulation time. Yes, coagulation time activated for there is APTTs, activated thromboplastin time. And SGPT, SGOT usually we don't go for, but yeah, if it is required, we can do that. T dimer and all are the test for cardiac arrest. CRPs, yes, inflammation can be one of the reason, of course. So CRP can be checked. Okay, so blood test, and then CT scan, then MRI, electrocardiogram or ECG, and then carotid. You have to do the carotid ultrasound also. So as I told you, it talks, or it shows, the carotid ultrasound shows us the exact location and the the inside culture of the carotid artery. Magnetic resonance imaging, MRI, which is majorly done for the ischemic stroke because it comes in the super slices, 2 mm, 1 mm, 3 mm slices. And then computer tomography is one of the acute diagnostic tool for stroke. Okay. This is again taken from the Lalpath. Okay, so in this present case, we did CT scan of the head, non-contrast, and we found there was no intracranial hemorrhage, no hemorrhage, but early ischemic changes in the left middle cerebral artery. Okay, so it was ischemic stroke. It was ischemic stroke, not hemorrhagic stroke, because there was no intracranial hemorrhage. There was no cerebral bleeding. There was no cerebral burst of the arteries, right? So it was early ischemic changes, which shows usually it is the ischemic stroke. Okay. ECG shows atrial fibrillation with the ventricular rate of 120 beats per minute. Then blood sugar was 180. Of course, this patient is diabetic. Serum creatinine was normal. INR was normal. Lipid profile was elevated. And this guy is also on atorvastatin, right? Dyslipidemia. So this is like, if we go to the final diagnosis of the patient is ischemic stroke, acute ischemic stroke in left MCA territory, likely embolic in the origin secondary to atrial fibrillation. Because of atrial fibrillation, the acute ischemic stroke has happened in the left MCA artery, left MCA territory, right? Left, left middle cerebral artery. Okay. So that is the final diagnosis of the patient. Angiography cannot be done here, Pallavi, because angiography is the test for cardio. Okay, for myocardial infarctions, usually when the problem happens in the cardiac arteries, when the problem happens in the cardiac arteries, right? So angiogram is not suggested. Angiogram is suggested if if the ECG shows any type of infarction in heart, any type of infarction in heart. Okay, carotid Doppler also can be done. Carotid Doppler, that's why I told na here. See, if you have seen in the last slide, carotid Doppler here. What is this carotid Doppler or carotid ultrasound? That is carotid Doppler only, na? Carotid ultrasound is carotid Doppler only. Okay. Now, acute management of stroke. Acute management of stroke. So, if the stroke comes to you, as I told you, it usually goes 87%. I mean, the recent guidelines says 87%, 85%. Acute ischemic stroke is 85%. Hemorrhagic stroke is 15%. So if acute ischemic stroke happens, if the patient comes to emergency room with acute ischemic stroke, and look at this, guys, look at this, very important acute management of stroke I'm telling here. So first check onset of symptoms within 3 hours to 4.5 hours, from 0 to 4.5 hours. Okay, if the symptoms onset is just within 4.5 hours, then immediately start IV TPA, LT plays. Immediately start LT plays in eligible patients. There is also eligibility. There is eligibility, like patients should not be on antiplatelets, patients should not be on any other thrombolytic agents, patients should not be very old patients. There are multiple restricted criteria. There are multiple contradicted criteria to start TPA. So before starting TPA, you have to find out if the candidate or the patient is eligible to that or not. Okay, if the patient has high bleeding profile, you cannot give TPA. Okay, so multiple causes are there not to start TPA. So first find out if the candidate is eligible for TPA or not. If the patient is eligible for TPA, then go for TPA within 4.5 hours. Within 4.5 hours. That's why I'm telling Rosini, like if the patient is having other contradicted problem means if the patient is already on antiplatelet drugs, that will increase the bleeding risk. If the patient is already on any other thrombolytic agent, that will increase the bleeding risk. If the patient is having the blood lithiasis or any other bleeding problems or any severe accident, that case also restrict you or contradict you to use TPA in such patients. Or the patient's age also more than 65 years. Usually the guideline says in more than 65 years, you should not go for TPAs. Okay. Sir, how to interpret ischemic stroke on CT or MRI imaging? That I will tell you while we are teaching in the class, because right now I cannot tell you. I don't have images also right now. I didn't get any image of CT or MRI where I can tell you. Okay. Yeah, if the patient is having severe kidney problems also, we cannot, usually in some cases we don't use TPAs. Okay. MRI is best in ischemic stroke, but CT scan is the preferred diagnostic tool for both type of stroke in emergencies. CT scan, CT scan is one of the emergency tool, and in acute cases we use CT scan first, and then later we go for MRI, because MRI will not tell you the acute symptoms, or MRI will not tell you the acute injuries. MRI will tell about the clots which are quite older, more than 2 hours. Okay, usually that is the major reason. Understand? That's why MRI is being checked, but not for the acute, or not as a acute tool. Okay. So surgery, I'm coming to that. Okay. So guys, listen, if the patient is acute ischemic stroke and the symptoms onset is within 4.5 hours, then you can start TPA only in eligible patient. And if there is more than 4.5 hours to 24 hours, then go for CTA again, and then, check. I mean, CT head you have to do, eligible patients you have to do then, and then, again, CTA head and neck. And if you find LVO, what is LVO, guys? Tell me LVO. Tell me LVO. What is LVO? Yes, 0.9 mg per kg if altiplase. I mean, yeah, that is the dose. I'm not getting into that deep right now, because that is otherwise will take 2 hours, 2.5 hours to for me today. Large vessel occlusion. Absolutely. LVO is large vessel occlusion, right? So we have to start right TPA within 4.5 hours. If it is 4.5 hours to 24 hours, then we check LVO, large vessel occlusion. Large vessel occlusion is what? Large vessel occlusion means the main carotid artery, the middle cerebral artery. Okay, carotid artery or middle cerebral artery occlusion is there. Then what we have to do? If there is, yes, there is large vessel occlusion, we go for within 0 to 6 hours. Within 0 to 6 hours, there is no need to go for MRI. Okay, there is no need to go for MRI because that can be seen easily in CT scan. Okay, and if it is 6 to 24 hours, then we go for advanced CT and MRI scan. Advanced CT and MRI scan. Sorry, then we go for advanced CT and MRI scan, MRI perfusion scan, right? And then we go for, what? Then we go for what? MT. MT is what, guys? Tell me what is MT? People fast. These are simple things. MT. What is MT in stroke? Check. Metric tone. What is metric tone? Mechanical thrombectomy, not metric tone, guys. Come on. Mechanical thrombectomy. Okay, mechanical thrombectomy. So what is mechanical thrombectomy? Tell me mechanical thrombectomy. What is mechanical thrombectomy? Mechanical thrombectomy is the surgical procedure, usually surgical procedure. Okay, usually surgical procedure, or we can, nowadays we have the angiograph, we have the catheters which can even take the entire clot out. There are two types right now. I mean, now we have surgical options also. We have angioplasty also, like where we put the catheter and we we revascularize there. Revascularize means we remove the clot, right? If there is LVO, like large vessel occlusion, then we usually go for the thrombectomy. Thrombectomy is the procedure to remove the blood clot from a large artery in the brain. Large artery in the brain, there are two things. One is surgery. Now surgeries are usually for that we usually, I mean, in the brain usually we go for surgeries. And we also go for a procedure like PTCA. Okay, PTCA happens in coronary artery, means in the cardiac arteries. Okay, but in brain we go for some different catheters, different minor catheters which do not injure the other vessels or other cardiac tissue, I mean other brain tissues. So there is a little different procedure. There is a little different procedure, but that happens from 6 hours to 24 hours of after stroke. Okay, 6 to 24 hours after stroke. Stents are used in stroke. Stents usually no. Usually, no. Usually stents are not used in stroke, but yes, in carotid arteries, yes. In major carotid arteries, when the carotid arteries are involved, large vessels are involved, usually stents are put in that. Okay, usually stents are put in that. But if the clot is in the peripheral arteries, if the clot is in the peripheral arteries, then we don't use, stents. Then we don't use stents. Okay, then we don't use stents. But if LVO is involved, definitely we can go for stents. Right now, there are the stents also for, LVO involvement. Okay, and then we can go for, after that we can go for neuro intensive care unit, like definitely that is one of the final thing. And this diagram has taken from Journal of American College of Cardiology. These are the guidelines for the acute management of stroke. These are the guidelines for acute management of stroke. Okay, now in this patient, guys, in this patient, look at this, very important. Our patient, now remember our patient had multiple risk factors. Our patient had multiple showed, atrial fibrillation, showed, ischemic stroke, and multiple other things, right? So what we have to give in the acute phase, there are two types of strategies we have to take. One is acute phase, one is post-acute phase. Okay, in this patient we have to take care of stroke by in two phases. One is acute phase. So first thing in acute phase is thrombolysis means we have to dissolve the clot by intravenous alteplase. Okay, TPA, that is TPA alteplase we administer after confirming for no contraindication. If the patient was selected, yeah, this patient was selected, and in this patient, our dose of alteplase was 0.9 mg per kg, 10% bolus over 1 minute, and 90% infusion over 60 minutes. Okay, that is how we administer the alteplase into the patients, right? 10% within 1 minute, and then rest of 90% over next 60 minutes, right? And time window, definitely within 4.5 hours of symptoms onset we have to give. Okay, otherwise we cannot give. So this patient came to the hospital within 2 hours. Understand, the first symptom, remember, this patient showed the symptom within 2 hours. And this patient came to the hospital within 2 hours of symptom onset. This patient came to the hospital within 2 hours of symptom onset, right? So within 4.5 hours of symptom onset, this patient got the intravenous alteplase. Okay, first thing we have to do is thrombolysis. Then the second thing, we have to check for blood pressure management, because this patient was hypertensive, and high blood pressure can, increase more problems, can also lead to other infarctions, and can lead to high peripheral resistance or raised peripheral resistance. And because of that, we have to give, before thrombolysis we have to control the blood pressure. Okay, we have to control the blood pressure, and for that we can give IV labetalol or IV nicardipine we can give. Okay, in that case we can give our IV labetalol or IV nicardipine, right, as needed, whatever was there we given. Then supportive care, first ensure ABCD, so airways, breathing, circulation. Defibrillation is not needed here, so ABC is required. And then blood oxygen control was given with the insulin, right? And then oxygen supplement, it was normal in this, though in this patient, but if it is less than 94%, we have to give the oxygen also, right? We have to give the oxygen also. Why sovoreltide? What about sovoreltide? Okay, sovoreltide also can be, no, usually in Indian scenarios, we don't use sovoreltide. In some hospitals, the recent guidelines says solid perfume. What is solid perfume? Tyval G. Okay, this is the brand name. Okay, supportive care we have to give. And then in acute phase, after blood pressure control, supportive care, and thrombolysis, majorly thrombolysis, we have to go for thrombectomy if it is needed. If the LVO is involved, we have to go for thrombectomy. Okay, we have to go for thrombectomy. And this should be from 6 hours to 24 hours. 6 hours to 24 hours. Though in this patient, mechanical thrombectomy was not required. It was not required in this patient. Okay. Post-acute phase here, antithrombotic therapy we have to continue, because once the TPA is given after 48 to 72 hours, we have to give some anticoagulation like apixaban, or we have to give NOAC. No, NOAC. Can someone tell me the full form of NOAC? TPA, not PTA. Then TPA. TPA is, guys, who will tell TPA? novel oral anticoagulant or new oral anticoagulants. New oral anticoagulants, not non-vitamin K anticoagulants. Tissue plasminogen activator. Okay, TPA is tissue plasminogen activator. Those are the new drugs which has been given to this patient and which are usually given for thrombolysis in patients of MI, in patients of stroke. Okay, in patients of stroke and in patients of MI, we usually give thrombolysis or thrombolytic agents like LT-plase, urokinase, and all. Okay, tissue plasminogen actor, NOAC. So in this, we give the NOAC apixaban. There are multiple, like tirofiban. Tirofiban is injectable actually. So apixaban, rivaroxaban, we can give. Okay, apixaban, rivaroxaban, we can give. Okay, in such patients, right? In such patients, we can give these drugs for the long term. Okay, for the long term, antithrombotic agent and antithrombotic therapy we have to do, and then lipid management. In this patient, this was 20 mg before, but we have to target now 80 mg daily because this patient's LDL was very very high. This patient's lipids were very high. So in this patient, we have to target now 80 mg per day at atorvastatin. Blood pressure, blood pressure control also is very important to control by 130 to 80. So this patient was only on amlodipine. So we have to change this amlodipine to some other drugs like beta blockers, which can also control the heart rate in such patients, right? Or which can also, or we can change to uh, some other calcium channel blockers also, which can help in atrial fibrillation also, and which can help in in our stroke also, right? But we usually go for beta blockers. Sometimes we usually go for ACE inhibitors and all, right? HDL, LDL was high. We don't know HDL of this patient. Okay, we don't know HDL of this patient. It was normal, I believe. Why not changing other statins? No, see, either you change to rosuvastatin, 40 mg, that's your choice. But we have to give, I mean, according to the conditions of the patient, and he was well tolerated to the atorvastatin 20 mg or atorvastatin 40 mg. So we can, increase the same dose to 80 mg because the patient was well tolerated to atorvastatin, right? So blood pressure control, and after blood pressure control, glycemic control. So there was the addition of SGLT2 inhibitors to this patient. SGLT2 inhibitors were added because this patient was already stroke, and there are the high chances of cardiovascular problem. There were the high chances of myocardial infarction. So that can help in, and because of that, because SGLT2 inhibitors are cardiac protective, are cardioprotective. Dapagliflozin, empagliflozin, canagliflozin. These are the drugs. I'm not going to the names, guys. Yes. Yeah. So these drugs can help. I mean, these drugs are usually cardioprotective. Okay. So we, to control the diabetes in this patient, we have added the SGLT2 inhibitor. So in such cases, we have to intensify the diabetes management by adding SGLT2 inhibitor or GLP-1 receptor antagonist. GLP-1 receptor antagonist, any example? Gliptins? Is it gliptins? GLP-1 receptor antagonist. Who is writing glimepiride? Glimepiride is what, guys? Glimepiride. Yes, glimepiride. Sulfonyl urease. Yes, glimepiride is sulfonyl urease. Glimepiride, glibenclamide, glycoside, glycoside. Those are sulfonyl urease. Okay. GLP-1 are semaglutide. Glutide or gliptins, guys? You are confusing me. Gliptins. Hmm. Gliptins or gliptins? Gliptins or glutides? Tell me. Array GLP-1 inhibitors are gliptins. Yeah, tide also. I said, tell me semaglutide and this gliptin, sitagliptin, are the same category or not? Acarbose is different. Oh God. So what is GLP-1 inhibitors, guys? Tell me. What is GLP-1 inhibitor? What is GLP-1 inhibitor? Yes, tell me. What is GLP-1 inhibitor? Yes, guys. Yes, tell me. Yes, guys. Wow. Okay, you guys are fighting. Okay, fine. Correct example is glutides. Semaglutide, liraglutide, dulaglutide. All glutides are the examples of GLP-1 inhibitor. Okay, GLP-1 inhibitors. Right. So now glycemic control, either SGLT2 or GLP-1 receptor agonist. Okay. SGLT2 inhibitors or GLP-1 receptor agonist, right? So here, post-acute phase, we have to majorly focus on the risk factor management, okay? Either lipid management, blood pressure control, or glycemic control. And along with that, lifestyle modification is very important. If the patient was, our patient was a smoker, so smoking cessation, regular physical activities, and dietary changes to DASH diet or Mediterranean diet. DASH diet or Mediterranean diet, we can go for, along with antithrombotic therapy, oral antithrombotic therapy, NOAC, like apexaban we can give, or rivaroxaban we can give to the such patients. Stroke prevention, definitely controlling high blood pressure, consume less cholesterol and saturated fat, managing diabetes, quit smoking, quit tobacco, maintain healthy weight, consume fruit and vegetables, limit alcohol consumption. Okay, guys, very interesting question to all of you. Exercise regularly, sleep apnea, control, and no drugs. So, my very important question to all of you is, what is the recommended alcohol consumption in the stroke or in the DASH diet? Or, I mean, not in this diet. What is the recommended alcohol consumption in such cases, according to guidelines, if you know that? NLRP3 inhibitors. Where? Did we give NLRP3 inhibitors? Yes, guys. What is the dose? No alcohol. Less than one drink per day. Less than one drink per day. Is it 20 ml per day? One to two drinks per day. Abstinence of alcohol. No alcohol. See, if it is ischemic stroke, 90 ml. Oh, yo, 90 ml. Who is writing 90 ml? Who is writing 90 ml? No alcohol. Definitely no alcohol. Now, guidelines says if the patient is chronic drinker, if the patient is chronic alcohol consumer, then every week 1 to 2 packs. Every week 1 to 2 packs. Usually there is the there is something called what we say it here. I forgot the term. I forgot the term. So sliding scale, I mean, for insulin we use sliding scale, but for alcohol something else. Gradually we decrease that, and ultimately we have to to reduce the to reduce the alcohol dependence syndrome, first we have to reduce to 1 pack per day, then we have to come to at the end 1 to 2 packs per week, 1 to 2 packs per week, and depends on the different things. So we have to look for the alcohol withdrawal symptoms also. Okay, alcohol dependence syndrome. Okay, we have to look for alcohol dependence syndrome, that is called ADS, alcohol dependence syndrome, right? So we have to look for that. Okay, that's why it is very, very important, right? So with that, guys, I think next thing is follow up and rehabilitation. That is one of the important thing to do in the patient. We have to follow up the patient for cardiac and neurological evaluations. For atrial fibrillation, like we have to check the ECGs every 3 months or 2 months, then cardiac imaging like echocardiography. For embolic source assessment, then rehabilitation. Physiotherapy is very important for motor recovery. Speech therapy is very important for dysarthria, and occupational therapy is very important for functional dependence. So after stroke, these three rehabilitations are very, very important. And then prognosis, recovery depends on the size and location of the infarct. Usually the patients are recovering very fast. If they are given TPH within 3 hours, there are the high chances of improvement because there is the dissolution of the clot. Okay, there is a dissolution of the clot. So it's very, very important in such cases. Rehabilitation is very important and integral part of stroke management, guys. Integral part of stroke management. Okay, so that is one of the important part of the stroke management. I mean, stroke prevention. Okay, so follow up and rehabilitation. So with that, guys, I'm done with my class today. Now my team will share the things. Class of recordings. Yes, definitely I'll share. Definitely. Now, guys, time for question and answers. Time for question and answers. By the time my team will share the link in YouTube and here, both the places. Okay. Yes, guys, from YouTube. Any questions, guys, from YouTube? Please ask me any questions if you have. Sir, can you please take one webinar on various job opportunities for family graduates? Next is that only, guys. Next is that only. Thank you. Oh, oh, wishing you a very belated happy birthday. Thank you, guys. But that's over 5 days back. That's 5 days back, not today. Okay. So don't spam the text. Don't spam the text. I mean, chat box. Don't spam the chat box, guys, please. Disulfiram should be given to reduce the alcohol. That's different thing. That's different thing. First, we have to manage the symptoms. First, we have to manage the stroke. We are not treating the alcohol dependence here. We are not treating, we don't want the patient to, we are not treating the patient for alcohol dependence or alcohol consumption right now. We are treating the patient for what? We are treating the patient for stroke. Okay. NLRP3 and NFKB, PIK, PI3K are major pathways for induction of MI. Yes, definitely. But we are not talking about MI here. MI, there is a very few chances of stroke. I mean, there are the chances, but only 1 to 5% of chances of getting stroke after MI. Okay. Any questions, guys? Am I having any questions? Can someone, Samriddhi, can you please share the link here? Survey for what is this? Subeshi for B Farm Espresso Assistant. Arun Kumar, I didn't understand that. Retake module 1 and module 2. No, if you want to get registered for module 1 and 2, definitely will do that. Can we use EEG as a diagnostic tool? No. EEG is not, EEG is for neurological functions, guys. EEG is not for hemorrhagic stroke or ischemic stroke. If ischemic stroke is because of the clot, hemorrhagic stroke was because of the clot burst, or I mean the way, I mean artery burst, okay, or bleeding, okay, blood leak, right? EEG is for the neurological functions. So Bhumika Sonar, EEG can be used to assess the neurological functions later, but not during the emergencies. Okay. Thank you very much, guys. Thank you very much. So my team has shared the link here, guys. Please fill the feedback form, everyone. Please fill the feedback form, and I'm sharing in the YouTube also, guys. Okay, I'm sharing in the YouTube also. Please fill the form in YouTube. I mean, I have given in the YouTube as well, guys. Okay, in the YouTube as well, I have shared the form. Please fill that form, guys. Everyone in the YouTube, I can see there are 83 people right now. Thank you very much for joining, guys. Thank you very much for joining, and I'll come back to Zoom now. What is the diagnosis is TIA? Why is acute ischemic stroke? Sir, the final diagnosis is TIA. No, where is TIA? Where is TIA? See, okay, you are talking about the diagnosis, or you are talking about the title of the webinar that I was supposed to take on TIA case only? No, 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 no. This case was not TIA. This case was proper ischemic stroke, what I have taken. Okay, this case was proper ischemic stroke. What kind of rehabilitation should be given to stroke patient? I just told occupational therapy and physiotherapy, very importantly for the muscular and motor functions. Okay, for the muscular and motor functions, we have to look for multiple things, like for physical therapy for the motor recovery, I mean for the senses recovery, speech therapy for dysarthria, and occupational therapy we usually go for the functional dependence, right? So these three type of rehabilitations are very, very important in stroke patients. Physical therapy like physiotherapy, speech therapy, and occupational therapy, very, very important. No problem, it's fine. Drug to restore motor functions, usually we give vitamins, but that's not the the with the that not the vitamins does not come with the immediate effect, so we used to go for the physical therapy and all. Okay, we see ear bleeding in stroke, please elaborate. Yes ma'am, definitely ear bleeding, sometimes nasal bleed uh, are there, sometimes nasal bleed is also there in hemorrhagic stroke. Okay, in hemorrhagic stroke, that's very much possible. Ear bleeding and uh, nasal bleed. Okay, that's very much possible. And sometimes you will see the patients who are, sometimes very few patients, but they come with the very much red eyes. Okay, it is completely about the involvement. When there is the retinal arteries involved, or the region near to eyes, the retinal arteries or frontal lobe is affected, or the bleeding is in the frontal lobe, that's very much possible to get the effect in the eyes. And usually when the peripheral nerves are affected, I mean not peripheral arteries, I mean peripheral, not nerves, I'm so sorry, peripheral arteries are affected, and if those are near to these regions like ear, definitely I mean the posterior regions, in that case ear bleeding is also very much possible, but that is very severe. In that cases usually the patient dies. In that case is very, it is very severe symptom when the bleeding is too much, more than 60 or 70 ml. And in that case, and the when the stroke, I mean the duration of onset is like more than 4.5 hours, more than 5 or 6 hours, and patient does not get to the emergency, or patient does not get to the tertiary care center, in such cases, yes, ear bleeding and nasal bleed have been seen. Nasal bleed is quite common than ear bleeding, because that if the frontal lobe is involved in cranial hemorrhage, then in that case you will get the uh, uh, like nasal bleed as well. Reducing alcohol intake can be called alcohol tapering. Tapering, it's okay if we call tapering, it's fine. Tapering, yeah. Tapering is the word, medical word. Why obesity is a risk factor for multiple disorders? Okay, anyone wants to answer this question? Very fantastic answer by Asutosh Kumar Prajapati. Why obesity is a risk factor? Obesity is a metabolic disorder. First of all, try to understand. Obesity is a metabolic disorder. That is the reason for multiple problems like diabetes, like hypertension, like dyslipidemia. And those are the direct problems. Those are the direct risk factors for cardiac problems. Those are the direct risk factors for even sometimes cancers now. Those are the direct risk factors for hemorrhage, stroke, multiple problems of deep vein thrombosis. So Yes, because that is the metabolic disorder that affects your metabolic, functions in the body. Okay. What is the difference between alcoholic consumer and alcoholic? Yo, I don't want to go to that. Alcohol consumption, alcoholic. I mean, see, alcoholic and alcohol consuming is same thing. Okay. If you go to the different terms like alcohol consumer can only buy but don't drink, that's different thing. I'll not go to that. Muskan, okay. How to identify myocardial stroke in ECG changes? Usually in ECG changes, it does not come. No, no, no quiz, only feedback form. There is no quiz today. Does stroke occur only in brain? See, look at me from here, above this part, because from here, your carotid artery will come from here, okay, from the aorta. Carotid arteries will go to the brain and supply the blood to the brain, right? Carotid arteries, we call them cerebral arteries, right? Carotid artery is in the neck. Carotid artery is in the neck, like usually in the back side of the neck, there is carotid artery. Okay, in the central usually, but a little posterior, little backside, so that vein carries the blood to the brain, right? And that's why stroke are affecting the brain only, because if the block is happening in carotid artery or the branches of carotid artery, which are called as cerebral arteries, posterior, inferior, or central, mid-central. So in those carotid, I mean, in those cerebral arteries, if the clot is happening or burst out is happening, there hemorrhagic or ischemic, any type of stroke is happening, that is happening in the brain. That's why only brain is affected. If the ischemia, like if the ischemia is happening in the brain, that is ischemic stroke. And if the ischemia is happening in the heart, that is called as myocardial ischemia. Ischemia is common both at both the sides. At both the sides, ischemia is common, but if it is happening in the brain, that is called as stroke. Okay, cerebral ischemia. If it is happening in the cardio, it is called as myocardium. I mean, myocardial ischemia or myocardial infarction, because that is in the myocardium. Myocardium means muscle or vessels of the heart. Okay. And if it is happening in cerebral, cerebral means the brain. Okay. Please share the PDF notes. Oh, PDF notes. Yeah, one more thing is there with me. Okay, guys. I'll share this if it is possible. I'm not sure because this is prepared by my team. I'm not sure if they will allow me to share this, but let me share this. This is a fantastic document my team prepared for me to teach you today. Here. Not this, yeah. No, not this, not this, not this, not this. My team prepared this wonderful document here. Yeah. See, my team prepared this wonderful document where they are differentiating all three types of stroke. All three types of stroke here. Look at this. Definition of ischemic TIA hemorrhagic stroke, pathophysiology, duration, symptoms, risk factors, diagnosis, treatment, acute, prevention, prognosis, key factors. They prepared a very fantastic documents differentiating all three types of stroke. Muskan, why are you asking this question again and again? What is the difference between alcoholic consumer and alcoholic? The same thing. Alcohol consumption and drinking alcohol or alcoholic person, darubaz, bevda, is the same thing. Okay. So sorry. Smoking is also a risk factor of a stroke. Of course, smoking is a risk factor. Of course, smoking is a risk factor. Can I leave the meeting? Yeah, if you can, you have no questions, then you can leave. Right now, only 50% of the people are remaining here. Does stroke occurs only in brain? That I've answered already. Sir, certificate will not provide after fill. Certificate will provide after filling the feedback form only. Samriddhi, can you please? Yeah, shared. It's again shared. Please do not share in the, guys, remember this. Please do not share in the WhatsApp chats, WhatsApp group. Okay. And guys, again, if you are interested in the course, you can purchase the course also. This is the last date today. This is the last date today. I'll share in the group also, and I'm sharing here also. If you are interested, let me share once more. Let me share the brochure with all of you. 1 second, guys. I'll take all the answers, questions. Wait. No quiz. Today, no quiz. 1 and 2, I'll tell you. First, you have to get the third now because third is going on right now. Okay. Third is going on right now. So first you have to take up the third, and then if you're interested, you can take the 1 and 2 also. Okay. Then you can take 1 and 2 also. Sir, please PPT share kar do. No, 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 no. PPTs cannot be shared, guys. My team will kill me. Okay. They prepare the PPTs for me. PPTs are very confidential thing. Arey, you can watch this recording, yaar. Come on. This recording will be there for everyone. Free of cost in our YouTube channel. Did you subscribe to the YouTube channel, guys? Subscribe to the YouTube channel. How should be a patient with hemorrhagic stroke having high BP of high HB of 19 should be treated? This is a very nice question. So this is called polycythemia. There could be multiple reasons for polycythemia, and polycythemia does not affect much, in such cases. So in such cases, we have to choose the correct, drug. Correct drug means correct anticoagulant drug. Okay. There is a hypertension called silent attacker. So it is the same term for stroke. No, 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 no. Stroke, I told you, stroke are two types. One is hemorrhagic, one is ischemic, and in that TIA is mini stroke. Okay, PDF form, sir, it is reoccurs. Yes, stroke reoccurs. Yes, stroke reoccurs, definitely. Sir, within 5 minutes of ischemia, neurons in the brain starts to die. Then how to say? That's why I emphasized on the timelines, 4.5 hours. Within 2 hours to 4.5 hours, we have to give we have to give TPA, and then we have to go for, if there is LVO, the major vessel occlusion, large vessel occlusion, then we have to go for the surgery or angioplasty. Daily class will start at 7 o'clock only, not daily, every Wednesday, 7 o'clock. Yes. Yes, recording will be available for all of you. So here is the brochure. Here is the brochure, guys. Okay. Here is the brochure I shared with you all. Okay. Yes, guys. So is there any emergency management of stroke? All are emergency strokes only, Anjali. I told acute thrombolysis. Okay, thrombolysis is the acute management of a stroke. I told that. In patients with high CKMB levels and troponin level, that is cardiac arrest, or that is like myocardial infarction. In that cases, the cardiac protection is also required. That is, first you have to check the angiograph. If angiogram is positive or angiogram is showing any clot, then you have to go for angioplasty or the revascularization or the antiplatelet agents. Okay, in such cases, it's very important. Cerebral stroke main factors affect. I told you guys, please check back in the recordings. Docs like rivaroxaban, apixaban preferred over warfarin in certain stroke prevention studies, particularly in setting of atrial fibrillation. Warfarin, hemorrhagic stroke. Okay. Ischemic stroke with atrial fibrillation, definitely warfarin. And rivaroxaban, apixaban, because apixaban and rivaroxaban are the latest new generation anticoagulants. Okay, novel anticoagulants or new oral anticoagulants, we call them. Those have the more potency or efficacy than warfarin. Okay, But in certain cases where is severe MRTR, mitral regurgitation, tricuspid regurgitation, and there are some other, cardiac functional problems like valvular problems or functional problems, functional, disabilities in the heart. In that cases, we prefer warfarin, or we usually give warfarin and acetylcholine. And one more thing, one more very important thing you have to remember, Anusri and everyone who is asking this question, rivaroxaban or warfarin. Warfarin we don't give usually when we look for the potency and efficacy when it is required. But warfarin is preferred over apixaban and rivaroxaban in the patients who cannot afford NOAC, because NOACs are very costly. Apixaban one tablet is around 60 to 70 rupees. I don't remember exact, but it is 70 rupees per tablet. And warfarin comes in 1 rupees per tablet or 1.5 rupees per tablet. So we have to look for the affordability also of the drug. Affordability of the drug is very important. Okay. Understand? I think Ramzia Meher also, there's the same answer. I mean, affordability is one of the major factor in the patients. What is seen? Okay. Hemorrhagic stroke with the traditional approaches. Surgeries, thrombectomy for hemorrhagic stroke. Thrombectomy is the, one of the emergency or acute treatment, acute management. Can overuse of sildenafil increase the risk of stroke? Yes, it is, because it increases the testosterone in the body. Okay, it increases the testosterone in the body, and that is linked with the peripheral resistance. Peripheral resistance, do you know that what is peripheral resistance? Peripheral resistance is directly associated with cardiac output, and cardiac output, high cardiac output can lead to high blood pressure, and that can lead to stroke or cardiac arrest or myocardial infection, anything. After completion of this course, can we include this in resume? Definitely, yes. Okay, guys. So with this, it's almost 9 o'clock. I'll take off. And thank you very much, everyone. From YouTube, there are no questions, I believe. There are no questions. Yes. Can stress be a risk factor of stroke? Yes. Sedentary lifestyle and stress are one of the major risk factors. Okay. So thank you, guys. Thank you very much and take care. Okay. Good night. Have a good food and see you. And certificates by Saturday evening. By Friday or Saturday evening. You are not asking me now only where are my certificates. You have to wait till Saturday or Friday. Okay. And only who filled the form will get the certificate. Thank you, guys. Thank you very much. Take care. It was nice meeting you, and it was a nice learningful sessions, and it was very interactive session. So I would like to thank you all for this session. Thank you, guys. Take care. Bye bye. Good night.